Welcome to Melanoma Insights for Professionals, brought to you by Melanoma Institute Australia. I'm Professor Georgina Long, medical oncologist and medical director at Melanoma Institute Australia. Welcome back to our special Vodcast series, Redefining Immunotherapy, Lessons from Melanoma. This is Ep.2, where we'll focus on the quest for smarter immunotherapy decisions, how we better predict who will benefit, how we treat and how we monitor our patients. If you haven't already listened, I'd encourage you to go back and listen to Episode 1, where we set the scene, looking at how cancer evades the immune system, how immunotherapy works, and why some tumours respond or resist treatment. Joining me in the studio today are my medical oncology colleagues from Melanoma Institute Australia, Professor Alex Menzies and Associate Professor Matteo Carlino. We have also Associate Professor Ines de Silva dialing in from Portugal. So we're here about to discuss the quest for smarter immunotherapy decisions. So what is it when a patient walks through the door that you use to make a decision about immunotherapy and the type of immunotherapy you're going to use?
So thanks, Georgina. So the first thing I think to say is that in some ways melanoma is a little bit more straightforward than some other cancers, where, to be honest, the vast majority of our patients, immunotherapy is likely to be the first line treatment, acknowledging there are some exceptions.
What exceptions are they?
Well,
I can't think of any myself.
Yeah, so the next patient with a cardiac transplant you see, you may pause before starting the immunotherapy. You may still give it, but I guess, for the vast majority of patients, the decision to give first-line immunotherapy in the metastatic setting is relatively straightforward.
So what is the issue then? Is it becomes what type of immunotherapy? And just before that, Alex, someone comes in, cardiac transplant. What's the data there with transplant and the immunotherapy we use? What's your go-to?
Oh, look, I mean, anyone with organ transplantation, there is risk of rejection. It is a concern. I think what we always have to do when we're thinking to weigh up decisions about patients is what options do we have available? What's the likelihood of success? What's the likelihood of toxicity? It doesn't change with immunotherapy than other cancer treatments. But as Matt said, I think with melanoma, given that we generally don't have much other treatment available, aside from targeted therapy for BRAF mutant melanoma, immunotherapy is a default. So it's a case of what type of immunotherapy we choose and what are the factors we're weighing up when deciding that.
Okay, back to you, Matt. So the patient doesn't have a transplant of some kind.
Makes the
maybe
day
have
easier.
a kidney. Yeah, no. They don't have primary sclerosing cholangitis. They may have rheumatoid, but let's not put that in it. What is the basic sort of thinking you have when a patient comes in the door?
I guess the general principle is we want a drug that's going to work. And by work, we mean durably control their cancer and potentially cure them. And ideally, we want that drug to happen without toxicity.
Melanoma's spoiled.
Now,
Gee, we're spoiled. I just have to say, we're spoiled that you sit there and talk about a cure for advanced stage melanoma. Yeah. So that's our goal. That's really to be clear. We're talking durable control, perhaps even a cure, if you want to use that word and you're brave enough. Okay.
And so, if you stay, that's my goal. I want the drug to work and I want to have no cost because we're greedy. We want no side effects and it to work. Now, that's easier said than done. You then have a question about how likely are the different options going to work. And we'll talk about how you really, in the standard of care, that means single agent anti-PD-1 or one of the two available doublets. And you're trading off the incremental increase in toxicity risk. Now, of course, you can still get a patient treated with single agent anti-PD-1 and have an awful toxicity. And you can still have a patient treated with doublet immunotherapy and it not work. But really, that's what I'm thinking about. I'm trying to thread the needle to get the treatment that works with the lowest risk of side effects. And to be honest, a treatment without side effects that doesn't work isn't that effective. A treatment taken to the extreme that works but leads to a life-altering toxicity is also not great. And we spend a lot of time thinking about how to make decisions based on one drug versus two. And I think in the future that may become more complicated, hopefully as we get other options. Historically we were really limited to single agent anti-PD-1 and ipi-nivo. That expanded when we got nivo-rela.
And what's Nivo-Rela, just for people listening who may
Yeah,
not know?
so Nivo-Rela is the second combination approved, and it's a combination of nivolumab, which we all know, the anti-PD-1 agent, with relatlimab, which is an anti-LAG-3 agent. Combination's been trialled in a number of other malignancies, but to be honest, the only malignancy where it's got at least a TGA indication, and my understanding is even an FDA indication, is in advanced melanoma. There are other LAG-3 PD-1 combinations out there in clinical trials, but it's another combination. And to be honest, as a clinician, while I think I have some hints about which patients get which of those three options, I wish I was better at it, and I wish I had better information to choose which patient gets single agent.
So they've never
which
been
gets the
compared
doublets.
head to head. I'm going to throw this one to Alex then. So Alex, right, Matt's outlined it beautifully. Generally, immunotherapy first line, except for those rare things. We've just got to choose between PD-1. He's saying it's simple. It's a walk in the park, melanoma, but he's got few little difficult... No, you didn't actually. You said it's a bit more difficult. So let's hear from Alex about
So yeah, I think what Matt was saying was
difficult.
immunotherapy or not, that decision's easy for the vast majority of people if we're talking particularly about advanced melanoma, but which drug you use is the challenge. I know we're going to be talking in another session about immunotherapy toxicity, so I'm going to sort of, we take that into a consideration. We're going to park that for the moment. That is really important for people, particularly advanced melanoma, but we also know the number one most important factor for patients with advanced cancer is survival. That is the number one driving factor across cancers. There's a lot of evidence to say people want treatment and survival is their greatest priority, often more than toxicity. So without spending time on tox, and with that as, I guess, the premise and the backdrop, we want to work out what is the drug that's going to be most likely to be successful. Because if we can get away with single agent, that's awesome, because we can also minimise the toxicity, and that's great. And really, it depends on, in my view, I think it depends, where is my starting position?
What do you mean by that?
So some
what is
people,
my starting?
I think some people in melanoma in clinic have a starting position of single agent is my starting position, unless there are factors which we'll get into that dial up the need for a combination.
Let's talk about it now. What are the factors that dial up?
So I think, for example, high burden disease, highly symptomatic disease, brain mets, liver mets, BRAF V600E mutant melanoma, probably mucosal acral melanoma subtypes. These are the subtypes where a combination is likely needed, particularly traditionally it's been ipi-nivo in my clinic. That's where I believe these people need combination therapy. Conversely, are there groups of people that can get away just with single agent confidently? I think it's older people, because particularly with a lot of chronic sun damage, head and neck primary melanomas, lung-only metastases, normal LDH. These are people that usually can be cured, and I use the word cured, with single agent PD-1.
It's interesting you mentioned liver mets and brain mets. I'd add bone mets to that. I'm just going to throw it to Anesh on that score. So classically, Anesh, we've always thought brain mets. We know, we've proven with the ABC study, it's the only randomised study of PD-1 alone versus PD-1 plus ipilimumab, or Nivo-Ipi versus Nivo alone, that showed the ipilimumab adds significantly to the cure rate. Let's use Alex's word. What about liver mets? How does that fit with brain mets and bone mets?
Yeah, no, that's a very good question. And I think, as you mentioned, Georgina, historically, we thought that brain mets were a site of resistance to treatment, and specifically immunotherapy, as we're talking here. But as you mentioned, ABC clearly showed that is not the case. So we have to probably stop thinking that. But differently to brain mets, liver metastases, as you mentioned, bone metastases, they have been shown to be a site of resistance. What do I mean by that? Well, we know from different studies, and that applies not only melanoma, but also lung cancer, that if we compare different sites of disease, liver metastases, they tend to respond less, not only locally, but that impacts also the overall survival. So basically, patients that have liver metastases, they tend to have a shorter progression-free survival, so they tend to progress more rapidly to immunotherapy, and also shorter overall survival. So
in other sites,
I agree
meaning
with Alex.
So the liver liver's
compared to
the
other sites,
canary.
exactly.
Yeah, liver's the canary.
Exactly.
It shows you you've got a
We
disease
don't
that's going to be more resistant. You
cor-
don't respond in the
correct,
liver, you probably won't
exactly.
respond if you have concurrent liver and lung, etc. Okay.
I've just got
Yep.
Which is
one other
interesting
way.
because lung seems to be better. Yeah,
Yeah.
what Alex
Yeah.
was saying.
Yeah.
Lung, yeah.
I have a slightly different way of looking at a couple of these things. So I think the BRAF V600E and the brain mets, almost in my mind, are predictive biomarkers for ipilimumab, right? The delta between that single agent curve and that ipi-nivo curve.
So you're talking 067, the BRAF mutant subgroup,
And
when you look at
your
the
ABC,
PD1 and then the PD1
Yep.
plus ipi, or in my ABC, PD1 versus PD1 plus ipi, the delta difference is
hazard
massive.
ratio, correct.
Yeah.
Whereas if you think of liver mets,
Yep.
in my sort of simplistic view, appears to bring both curves down. So it's a bad prognostic
That's
marker.
right, prognostic.
But I'm
That's
less
true, that's
convinced
true.
it's predictive because the delta is not that impressive. The
I
hazard
can
ratio,
add to that.
it's incrementally
Yeah.
better, but it's not. And so I think an S.
But it's still better.
Yeah,
Correct.
But it is a thing of resistance,
Yes.
unlike the brain and the lung,
So
and etc. Yeah.
So we want
Prognostic,
to
not
give the
predictive.
best, basically.
Yeah. Okay. So back to walking through the door, and you
Yeah.
both were chatting about how do you choose between single and doublet, and then I'm going to ask you between the two doublets. So you mentioned, Alex, all the straightforward brain, V600E, young patients, acral, mucosal, etc. High LDH, high burden, high kinetics of turnover. Tell me,
So-
what do you do now?
Yeah, so I think in my mind, a bit as Matt said, I think it's very clear in my mind who ipi-nivo would be the default for. And it's those things we mentioned, brain mets, I think liver mets, just because if they've got bad disease, you've got one crack, you go in with your strongest, most powerful combo, BRAF V600E, melanoma, etc.
That's changed, though.
I've talked about single agent, which is, there is a room for that. What's different and what's new is nivo-rela. Because we know compared to nivo alone, there is a greater response rate, there is improved survival. But what I'm still not totally clear about yet is who are those people that benefit from the addition of rela? Are they the same people that would have got additional or maybe greater benefit with ipi? So I'm finding it difficult to know who do I bring down from ipi-nivo to nivo-rela. I think there's probably many that can lift up from single agent PD1 to nivo-rela. But it hasn't really changed my mind on the position of where ipi-nivo is. So I don't think that's changed my practice. I don't know about you, Matt.
Yeah, so I agree. Two things that I find interesting. I think the things that make you choose between nivo-rela and pembro or nivo are often the patient factors.
Yep.
So if they park their walking frame at the door, or worse still, need the walking frame to get to the chair, that clearly pulls you down towards single agent. But you're right, which ipi-nivo patients become nivo-rela is harder in my head. And the other thing that's really, I spent a bit of time thinking about last week, about a specific patient, is now with the change in the PBS listing, we can use low-dose ipilimumab. And the low dose of ipilimumab, and I think it's important that low dose means different things to different people, but at least for me, low dose means 1 milligram per kilogram every 3 weeks. And that dose of ipi-nivo, I haven't decided in my head how that compares toxicity-wise to nivo-rela.
And we'll get to that, actually,
And certainly
in our next bit.
I just thought about it almost on the fly with a 78-year-old woman in front of me.
So you bring up, again, it's about toxin efficacy. Alex nicely summarised. Between nivo-rela, ipi-nivo, we don't have enough data or information to drive that decision. But one thing we do know is the ipi-nivo patients are still there, and they're the V600E, acrals, mucosals, brain mets, etc. Need more data. They'll never be compared head-to-head. However, I will give a plug for Neo-Irene clinical trial because that will absolutely give us some efficacy data on high-dose ipi-nivo versus low-dose ipi-nivo versus nivo-rela versus triple checkpoints in patients who are biomarker selected to be poor, as in non-responders to PD1 alone, i.e. pembro or nivo. So with that segue, so we're going to biomarker test patients, and if they're going to be predicted to do poor, they're going to get 4 different arms, and we're going to answer that question. Which of those are the most active in a bunch of patients? So let's move then, you've nicely highlighted some of the issues and how we decide, to other biomarkers for patient selection. So we've talked about clinical. Let's talk about tissue biomarkers just for a minute across all cancer.
Okay, so
Can I maybe just stop you there before we could jump into across all cancer? In melanoma, I think it's probably important. In melanoma, BRAF and the BRAF subtype is important.
E versus K.
PD-L1, where does that fit in melanoma?
Good question. Anything else?
Short answer is I don't think it does, and I don't use it. And then you've got TMB and interferon.
So
I think they're the
PD-L1
basic biomarkers that are in melanoma, but before we jump to
PD-L1, the EMA might disagree with you though if you think it doesn't fit.
So let's just talk on that for a minute. PD-L1 is not used in melanoma regularly. However, it is a biomarker. It's just not highly sensitive and specific. We know that 25% of people who have PD-L1 negative on immunohistochemistry can still respond to PD-1 alone. And it's more the dynamic. So when you give the PD-1, you see the PD-L1 expression go up on treatment. But we know if your PD-L1 expression high, your response rate goes right up to 60%. So it does select a little bit. It's just not highly sensitive and specific, and therefore we don't use it because if you're negative, you're still going to get immunotherapy, right? So yes, but you may have a lesser chance. So it may help inform your discussion with patients, but we don't routinely do it.
And the reason why I say that is in other cancers, PD-L1 is thought to be far more important and is often required to select therapy.
I'm going to challenge that. There is a rate of response to PD-L1 negative in other cancers. Now, it's not my thing, but we've got people here who do GI and lung as well. But so PD-L1 negative, they still can respond.
No, I can start with lung. I love that discussion because I agree that PD-L1 has a role, but I also agree that we don't use in melanoma. So let me try to explain. So PD-L1, as Georgina mentioned, really tells us a little bit how the immune system is there and how the patient is going to respond. It's not 100% we know, but it tells a little bit. So we know that if PD-L1 is high, the chance of response is higher. But if PD-L1 is negative, there's still a chance. So because in melanoma, we don't have any other treatment, as we mentioned before, we don't use it because we want to give at least some chance for the patient to respond.
And be cured.
Cancer, which I can talk. And
cured. Exactly, we're going for cures, so the stakes are higher.
That's right.
Yeah.
Because even though the percentage of response is lower, if they respond, it's long term. We probably are curing these patients. In lung cancer, because we come from a different background where we have other treatment options, including chemotherapy, that's where PD-L1 might be more helpful in a sense that if we really identify the subgroup of patients with a high probability of response to PD-1 alone, so then that's why PD-L1 is used as a biomarker to select these patients that have a high probability of response. And I have to say,
and can avoid chemo.
High,
and can avoid chemo.
And we have a great response. And I have to say that I'm going to throw an idea out, but patients with PD-L1 above 50%, I believe it corresponds to our melanoma. Like we select this group of very immunogenic. So I think that's to put a little bit more information on that. I think it's a matter of what you have available to treat the cancer. Helps a lot how we use the biomarker.
Okay, so we've talked about patients who walk in the door or the clinical factors. We've talked about PD-L1 now. We've talked about it in other cancers and melanoma. Alex has made the point, really, it's about melanoma we're talking about today. Any other comments on biomarkers in the tissue?
So I think TMB and interferon, I think, are the two
more
widely studied.
And I would say outside of melanoma, the biomarker, which is, I think, the strongest and the only situation where whatever cancer you've got, it then equates to melanoma, is microsatellite instability. If you have an MSI-high cancer, no matter what it is, where it came from, those patients should get first-line immunotherapy to the point where they're ahead of us. You know, there are patients with rectal cancer where, based on relatively small studies, we've taken patients who are getting radiotherapy, chemotherapy, often a permanent stoma, and in the space of one ASCO presentation, you know, those
complete retention of anatomical area.
No early
pain.
menopause for women, etc.
It's fantastic.
And so I think MSI-high, in some ways, is more important than melanoma because they respond as well, if not better. They interestingly now have the same question: ipi-nivo versus single agent for both
They're about a decade behind.
Correct. No, but you treat it like melanoma.
And we're lucky in melanoma we didn't have legacy drugs that we have to try and ethically and also we're going for cure here. We're going for cure. It's a completely different paradigm now.
And certainly that legacy drug thing is an interesting point. I think the rectal cancer data was so strong, a single arm study could replace radiotherapy in a blink. But if the data's slightly less strong, instead of having a response rate of 100%, you've got a response rate of 40 or 50, say, it is harder to replace a legacy drug. You either then need to do a randomized trial, or what conservative drug development does is start with
combos.
Here's my standard of care and I add.
Yes, and I think that's a very destructive and not very scientific approach, which is why neo-Irene is actually putting things on its head in terms of going earlier in cancer, biomarker selecting the people who will not respond, and then using experimental approaches early in the disease course. And that's putting cancer...
And just one other thing about global biomarkers. If we have MSI-high as the, almost exception of the rule, I'm less convinced by TMB, and I think, you can get a relatively high TMB colorectal tumour, except the MSI-highs, the response rate is quite low. So the influence of TMB is also tumour specific. So this idea that if the TMB is above 10, you get PD-1, just because you can, and it's FDA approved and you can now do it in Australia, doesn't mean it's the best option, particularly the best first line option. So TMB, complex biomarker, MSI, simple.
Okay. Well, thank you all for that discussion. I think we could sit here and talk for an hour about that. We haven't delved into everything, but at least we've touched on the major issues. The clinical aspect of choosing between doublets and single agent, the biomarkers, PD-L1, tumor mutation burden, interferon gamma, and MSI-high. And we've talked about how we put all of that together to select patients, and clinical trials are still where it's at because we haven't cured everybody. Thank you for joining us for Redefining Immunotherapy Lessons from Melanoma, brought to you by Melanoma Institute Australia and made possible by an unrestricted educational grant from Bristol Myers Squibb. We acknowledge the Camaragal people as the traditional custodians of the land where we have been recording today, and pay our respects. This discussion was accurate at the time of recording, April 2026, but may not reflect the rapidly evolving treatment landscape and approvals in Australia. For more practice-changing education, sign up to our Melanoma Education portal at melanomaeducation.org.au. Thank you for listening.